renal. Y'all should kind of start putting the pieces together between A and P and this, because aren't y'all doing cardiac right now?
Yeah.
So maybe this will help, kind of, because we have to do the physiology for this to understand how meds works, and that may help with anatomy and physiology. Okay.
I doubt it, but go ahead.
Are we starting from the beginning? Now we're just going to go over, get your notes out of your PowerPoints from yesterday, and then that way we can just make sure I'm going to review. Because I know when you're busy talking and listening the first time, you can't write everything down as fast. So today I'll just kind of go back over and make sure you jotted down what the pertinent stuff. Make sure you notes. Okay. And then the last little bit of this unit won't take us long, so we'll do some funny stuff. All right. So on A and P, your heart has 4 chambers, right? The atrium and the ventricle. These can get out of whack because usually it's bump, 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 bump. Right? The atrium is the top, the first beat you hear, and then the bottom is the ventricles. Okay? And blood is circulating through it at all times. Sometimes the atrium get out of whack with the ventricle, and that's what throws it off into a dysrhythmia. So there's lots of meds we can give for that to help slow it down or get it back into rhythm. One that even stops it. All right. And then also the other issue you have in cardiac meds is that even if the heart's in regular rhythm, these might be under too much pressure. Because remember, you're going to go right atrium, right ventricle. Left atrium, left ventricle. This is coming out from where? The superior, inferior vena cava, right? It's coming from the body. So if this is under high pressure coming into the heart, that's going to put a lot of pressure on this right atrium, isn't it? Mm-hmm. Okay? And so then it has to work hard on its preload, filling up. Remember the little picture of the little can dumping it in the heart. And then when it's leaving, left atrium, left ventricle, it's going out into the body, but it's coming from the lungs, right? And going out into the body this way once it leaves the heart. So when it's coming back from the lungs into the left atrium, it's going to be under pressure, right? Because if this pressure in this vessel right here is too high, this pulmonary vessel is too high coming from the lungs, then that's going to put a lot of pressure into my left atrium, left ventricle. And then same here. If this vessel that is going out to the body, which is what? Which one is that? Aorta. If it's too stenosed or clogged or narrowed or constricted, that's going to push more pressure that my ventricle has to push against. So that's going to increase my cardiac workload. My heart has to work harder to pump against that real high pressure, and then that makes me have lower cardiac output, less blood going out to my body that needs it. So what we do with meds is lower that pressure with various meds to help dilate it, lower the pressure, and then your heart doesn't have to work so hard and it'll last longer. Because when your heart works harder, it's going to play out faster. Okay? So some of the meds we use to dilate, it's one way you can lower the pressure. You dilate all of those vessels. Remember, these meds don't know that they're just going to be cardiac. They go all over the whole body. So they're going to dilate. What does dilate mean? Open up. And so they're going to dilate those vessels, in the heart, but then sometimes all over the whole body to help blood flow. They lower that pressure and get that blood flow in there. So one of the first ones that we have are nitrates. They're the universal vasodilators. They're going to open you up. They work directly on smooth muscle. And which is our smooth muscles that we're really worried about right now? All our vessels, our blood vessels, our arteries and veins, those are smooth muscle. That's how they constrict and dilate, because they're muscles. Think of little garden hose tubes. And they can open and close, okay? So that's what these drugs do. Nitrates work directly on those smooth muscle cells to help dilate those vessels, all right? When they do that, that decreases the need for oxygen. The heart's not having to use as much. It's not stressed. It's not straining. And so that's a good plus for those, right? And then they also help increase collateral vessel circulation to the heart. And collateral is all the extras. Okay? coronary arteries and vessels that actually feed the heart muscle itself. All these on the front that you see, the heart's a muscle, just like the leg muscle or arm muscle. It's got to have a blood supply. And so if these get clogged up, there's no blood getting to that muscle, what happens? It's ischemic, it cramps, and what are we having then? Chest pain. Angina or chest pain, heart attack, right? So that, when they say collateral, that's all this extra, okay? So it's going to open those up too because I want my heart muscle to be working. And so that's what those are good for, right? Nitrates. Now, who can tell me that's a nitrate? A medicine. Ooh. Nitroglycerin's one of them. That's on your book. There's a whole, towards the end of the chapter, there's a list of every med that is in this chapter. Yep, nitroglycerin pump or spray. That's a slow way. Deal, good. I'm looking
204.
204.
Oh no, that's never mind.
Page 225, there's different ones, okay? It tells you for every category that we're talking about in this chapter. Generic and trade names, okay? So Izardil, nitroglycerin, and nitrobid, those are all in the nitrate category of vasodilators. Which one is the one I can put under my tongue? Nitroglycerin tablet. What are the things I got to remind my patient about on that one?
1 every 5 minutes or more than 3.
And so, how do they need to store it though?
In a little glass container in a dark place.
It used to say if it didn't fizz, it didn't work. They don't say that now. If it doesn't give you a frontal headache, then it's gone bad. Okay, so you would teach that. If they're not feeling a frontal headache, then those pills are expired. They're no good. No wonder they're chest pains.
So they're always getting headaches with them.
Because it's a massive dilator. When you put it under here, your under your tongue is so vascular, so it absorbs so fast that it just boom opens you up, and that's why you get all of a sudden there's no blood flow. So it's just like if your heart wasn't getting blood flow, you have a cramp here. That's why you get a frontal headache, because that part of your brain's not getting that blood. All right. So what else about nitroglycerin?
Keep it out of sunlight.
What's a nursing measure that you've got to watch for? If somebody has had 3 of these and they're 80,
Their low blood pressure.
they're going to bottom out. Blood pressure's going to bottom out. Okay, so they need to be by their 3rd one where?
At the
Somewhere
ER.
getting help. Right.
You gotta make sure they don't take tartrazine in it.
Tartrazine may throw them off. Alright, so nitrates are kind of a big deal. You don't have to know about those, okay? Let's see. The other group is calcium channel blockers. And I gave y'all in that little handout I gave you today, that little packet, there's a bid on the front. It says antihypertensive because calcium channel blockers are vasodilators and they're also antihypertensives. Because when we vasodilate or open, what are we doing to the blood pressure? We're lowering it. So these are dual drugs. They may give a calcium channel blocker in an emergency, but then you can still take that or a nitroglycerin on a daily basis in a smaller dose, right? Because they're going to help control blood pressure. So calcium channel blockers do that. They're going to dilate those coronary arteries. That's what these are, the ones that supply the heart muscle itself. Those are your coronary arteries, okay? They're going to reduce that response of the electrical conduction system. Did y'all talk about the electrical part of the heart yet?
We only talked about flow.
Okay. SA and AV nodes are your kind of your pacemaker in the heart. They're the electrical, like your wiring in your house, and they're going to tell the heart when to beat. They get that impulse from the heart, from the brain, and it's like sends an electrical shock to the SA and the AV node. Now, when that's firing like it's supposed to, SA hits and then it goes down to the other one, AV. That's what makes the heart pump. If that electrical system gets off balance, because I've got too much in my cells, remember all my pluses, I'm just going like this. It's like a short circuit. If you've ever seen electricity firing off, that's what it looks like. And so, what these do is slow that response so that if it's going off crazy, it gets me slowing down to where it's back in rhythm again. The SA hits and the AV. SAs and the AVs. So they help slow that electrical conduction system of the heart down too. Gummit, are we going to fight this battle today, I guess? So calcium channel blockers are good. When they do that, what do you think that does to our heart rate?
It speeds it up, yeah.
Why would it speed it up?
Because it's causing the heart to work hard to get it.
You can change the settings on your computer so it won't fall asleep.
Okay, I need to do that on break. Alright, so reduce the response of electrical conduction system. It might slow your heart rate down a little, okay? Because if I'm slowing down the pulse, then it's not gonna be as fast of a beat. Alright? Okay? Now if I dilate too much, then the nervous system is gonna override that and say, hey, your blood pressure's dropping too fast, now you gotta speed up. Okay? But ideally, calcium channel blockers are there to just slow it down. And then you got peripheral vasodilators. What does peripheral mean? Woo! Fighting y'all today. Valentini. Peripheral just means the rest of your body, extremities, just like the peripheral nervous system. When you do that in AMP, you got your central nervous system right here in the center, your brain, spinal cord, and your peripheral nervous system is everywhere else, not the rest of your body. Yes, you did, because I told you that on our string day. I told you that. So, peripheral just means outside, like the outer parts, the outer rim of the body, okay? All your extras, extremities, okay? So, our arms and legs sometimes get clogged up. Like we said yesterday, who are my people who don't have, my patients that don't have good circulation? Diuretics, smokers, somebody who has poor circulation. Maybe they just have peripheral vascular disease where they're, I'm sorry, it's just, can't help it. So when you hear of it, it comes out. But that's what happens. Over time, those muscles, smooth muscles, that are used to expanding and contracting, the cigarette chemicals in it make it not be able to expand and contract. So then it stays contracted, and then I have no blood flow to my feet. And that's why smokers have peripheral vascular disease. You have cold feet that they try to stick on you in the night. And gross feet. Big, thick toenails. You telling y'all your secrets? Alright, so we give these for that too, because we want to expand and open up those arteries everywhere, in their arms and legs, right? Every part of our body needs circulation. Okay? Okay, so here's some of our uses. Nitrates, that's our nitroglycerin. If it's acute, like a heart attack that's happening right now, I'm going to give it in an IV form. If it's chronic, I can give those as little tablets, or I can give a daily nitroglycerin. What's the nursing measure I told y'all about if you're giving acute nitroglycerin for an acute attack, IV? How do I have to prepare that nitroglycerin? In a glass bottle. It has to be in a glass bottle. Because remember, the half-life's very short on that nitroglycerin, and we want it to maintain in that plastic, like our other IV bags, will just deteriorate it. So nitro should always be in a glass bottle. So we can give it daily as a lower dose, we can give it in an acute attack. Calcium channel blockers also help relieve angina, or chest pain. And then they're going to treat those cardiac dysrhythmias too, because remember, they're the ones that are working on the electrical system. And anytime we dilate, that helps lower our blood pressure, so they're also used to treat hypertension. Peripheral vasodilators are used to treat that leg pain. Intermittent claudication is a lot of times what they feel like cramping in their lower legs because they don't have a good blood flow down there. Okay? So those are all in your book. What meds are in which category? We're going to play a little name the med game later. Yeah, I know y'all are excited. I can tell. Alright, so here's our adverse reactions, the bad things that we got to watch for. Anytime we're putting something in our patient's body, we really need to be paying attention to what's going to be happening to them, right? We can't just give them a pill and walk off, especially something that's going to control their heart rate or the blood pressure, because these are the ones that will definitely kill them, okay? So nitrates, going to dilate us. Watch for flushing, postural hypotension. What's postural hypotension? When I try to move them around, they're going to collapse because they're not, their blood pressure's so low, okay? Who's highest risk for that? Older adults, or real weak already, like if they're dehydrated or immunocompromised. Tachycardia. Why? I thought you just told me that this was lowered my heart rate. Why does it cause tachycardia? It's your body's alarm system, right? To kick back in, it thinks that you're going into shock because your blood pressure is dropping. So if it gets too low, an adverse reaction is it's something we didn't intend on happening, but that's what the body does to preserve itself, and it spikes your heart rate back up, okay? Confusion, dizziness, fainting, headache, lightheadedness, vertigo. What's all that because of? Decreased blood flow to the brain causes altered level of consciousness, and all that falls under altered level of consciousness, right? Weakness, drug rash, pruritus, skin lesions. Any drug you give is going to have that, but sometimes it gets really excessive in these. And what's that skin issue we looked up yesterday called? Stevens-Johnson syndrome. Okay. Sometimes if they overreact to it, it comes out as their skin reaction, and so they'll have that. Stevens-Johnson syndrome is an extreme rash from a drug. Okay. And then peripheral vasodilators, they're going to cause headache again because we're dilating. Brain that's not getting enough blood flow. Same reasons: weakness, tachycardia, flushing, hypotension, all that. Okay. So those are the things you're going to be watching for in your patients, right? Right?
Yes.
Okay. Just checking. I hope you are. Ooh, drug interactions. These can definitely make things worse if you're taking a lot of these. So we have to be super careful when our patients are on these type meds to really review their med list, okay? Increased effects of atropine. What does atropine do? Yeah, speed you up. It's like epinephrine, okay? So if I'm really, really low, taking this nitrate, but then somebody gives me atropine to speed me up, it's like giving them a double dose. Antidepressants, it can amplify that and be kind of dangerous for them, okay? Yep, this is the one that should not be taken with Prazosin. And that was actually one of your drug cards that very few of y'all brought up yesterday. Did everybody do their drug cards? Josh? Drug cards? Okay. So, if you did your drug cards, you'll know that that was one of your drugs that you had to look up, okay? So, on the test, you're probably going to have questions about that. And then peripheral vasodilators are stronger if you use antihypertensives than alcohol. We already said don't take any meds with alcohol. It just skews everything. Oh, that doesn't make it. Any questions on the anginal, the vasodilators, all that? Anti-anginal. If I have peripheral vasodilator patient who's taking these peripheral vasodilators, why would he be taking it first of all?
A what?
Peripheral vasodilator. Why would
Circulation in the
it's got poor circulation in lower extremities. So what are your symptoms you're going to see? Without even asking him what meds he's on, you should be able to look and tell me.
Edema, discoloration.
Blue lips?
Not in his feet.
No, blue lips.
What about him? We're talking about if you have peripheral vasodilation.
Oh, never mind. Sorry.
Okay. So if they're taking that, they're going to have cold extremities. They're cold to the touch. Their feet are cold because they have poor circulation, right? This is why they're needing it. They have thin, real shiny skin. So you can look at it and see, and you're like, oh, wow, they got bad circulation. They'll have loss of hair growth. Why do you think that is? They're not getting any blood flow down there. First thing that goes is stuff we don't need, so they get rid of the hair loss. Their hair falls out down there, okay? Pain in their legs because of the clotting or the intermittent claudication. They're not getting enough blood flow, so they'll have cramps.
Hair on the legs.
Yeah, the hair on their legs. Alright, so that's what those are for. So you might have that scenario question. This patient, you're on upon assessment, you notice they have very thin, shiny skin in their lower extremities with loss of hair growth. What med would you think they're on? Or what med would they definitely need? Exactly. Alright, so what you're going to see as a nurse, put all those puzzle pieces together, and then what's the treatment for that, or what's the treatment for that, okay? Because that's how these questions are going to come out today. When I have a calcium channel blocker that I'm giving my patient, what's it blocking? Calcium. What's calcium do? Excite the cells, the party. It's a plus. And so, sometimes that's a good thing, but sometimes we're already too excited. We don't need any more excitement, do we? And that throws our heart rhythm off and stuff, or we tense up. So calcium channel blockers help with that. They dilate, and they're also good for dysrhythmias. Okay? Everybody good on those? Right. Then we have antidysrhythmics. These are drugs that are for what?
Cholesterol. No. Oh, I'm sorry.
Y'all smoke crack or something? What is happening in my smart class?
It's to get the heartbeat going.
Right. If dysrhythmia means what?
Heart rate.
Irregular heart rate. And so dysrhythmia, or antidysrhythmia, is for getting us back on track. Okay? So you've gone to lunch, you smoked crack, and now you're in a dysrhythmia. You have to take some antidysrhythmics. We have too much calcium in our system, or something that's plus. What is in crack?
We had a party.
I don't know. Too much plus. Okay, so for class 1, there's your. Remember, these are to help numb it up, kind of relax it, right? With a chemical. So remember, they're going to end in like procainamide, cyanide, all those little shortcuts. Did y'all look at that shortcut of the names I gave you, what it ends in? That'll help. Okay. How can they stop a dysrhythmia? What do? What does it mean when they say lengthen the refractory period? What is that?
They block the sodium in between beats.
They block the sodium, that's right, because sodium is a plus. So they're going to block that.
And slow your heart rate down.
Yes. So they block sodium because sodium is a plus. We don't need a lot of pluses when we're already plussed up. Okay? And so then, because that's an exciter, so then when they block that, that slows down our beat. The refractory period is where it's filling up, it's taking time to fuel up again or fire up again in order to make another beat. So it slows down that refractory period. Or the, like repolarization, or I'm trying to think of something y'all can relate with electronics. I have none. Blank. What's something that you have to wait on? Like, okay, you know those old light bulbs that you like had to wait on? They start off real low, and then all of a sudden they get brighter and brighter, and then they explode, and then you have to wait again. So think of that. It's like really slow to fire up, and then it gets brighter, 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 and then it bursts. So the time from when it bursts to where it's starting to glow back and start up again is your refractory. Just firing, refiring. It has to load and refire, load and refire. That's the refractory period. I need some up-to-date examples, don't I? Okay. All right. Well, I had to teach this to old people for 20 years, so they remember those cameras with the flash bulbs. I've had to relate it to them. Now I got to turn the other end of the bulb. No. Just the gas in it. Okay. All right. So class 2s. What are those? What's the LOL mean?
Beta blockers.
That's our LOLs, our LOLs. Those are our beta blockers. What are they blocking? The beta receptor sites. Okay? They block the beta receptor sites. Some of them can do, there's beta 1s, there's beta 2s. Some of them are picky. They only do block beta 1, some block both. So, but they end in what? LOL. Those are our LOLs. And so, when they do that, they're, again, slowing down that excitation. They're telling the heart to chill out, to relax, okay? Because it's too spastic right now. It's like an ADHD kid in a candy store. And so they're having to slow it down, all right? Amiodarone, another good one. It lengthens the time it takes from one cell to fire to the other. Remember how White said like they're lined up? This is the cells in our heart, on our heart wall. They're all lined up. And that signal's coming down from the SA node to the AV node. And it's going to take this one, this one, this one. You know, it's just going to go in a circle, a line. And if it's going too fast, that's when we get out of rhythm. So these drugs slow it down to where it's slower, helping it get back into a regular rhythm. Okay? And then verapamil. What does it do? It's a calcium blocker. Okay? So it's our calcium channel blocker. Right. It's just slowing it down again. Hopefully allowing it to relax a little bit to where it can catch its breath and then start back on a regular beat. Okay? So class 1s block sodium. Class 2s are the beta blockers. They just slow down the excitation of the heart. Class 3s they also block potassium. Amiodarone. It's blocking potassium, which is another plus. They're a plus. And so we need less of those sometimes, right? So just slow our heart rate down. And then class 4 prolongs the resting period. Those are the calcium channel blockers. They give it time to rest. And that was the thing we talked about the gun. It has to take time to load it, fire, and then take time again to reload. Same with these. They're just slowing all those cells down, the firing of the cells. Everybody got that? Sorta. Y'all are not excited today. Y'all are not pluses today. Y'all are sedated. Y'all are post-AP. Post-AP low. Alright, so she got you? You're done? She lowered your refractory period?
Yeah.
Alright, so quinidine and procainamide. Those are still the same things. They're going to just slow the heart rate down. Hopefully that will decrease that excitability in those cells. Slow it down, okay? Bertilium, what's that one for? Slows down the ventricles. So if I ask you which part of the heart is bertilium responsible for slowing down, would you know? Because you're going to tell me what? The ventricles, okay? Got it. And also it's going to slow down that norepinephrine release. Remember, norepinephrine is like epinephrine or adrenaline. And so it can slow that down or block that, bertilium can, and that is what helps slow the heart rate down for that one, okay? That's how it works. Remember that electrolytes move in and out of the cell. Remember they have that cell membrane. So potassium, you have sodium going in. It's called a sodium-potassium pump. And y'all will learn about that in AMP. For every kind of transfer off or trade out. And so you're going to have to keep it in balance. However many positives go in, positives have to come out. If we get too many positives in, and there's too many in the party, what happens? Too excited, and I'm going to go crazy. So that's why these are kind of helping with that balance. They block it because the body realizes there's too many positives in the cell and they block it. Okay? And that's what depolarizing is. It's firing off, it's starting back over. Okay? Lidocaine is one that we can give IV that helps slow down that heart rate, slow down those electrical impulses. It's very sensitive. You have to be real careful and titrate it like we did with your IV drips. Because if you slow it down too much and numb the heart muscle up too much, what's it going to do? It's not going to work anymore. You have numbed it up, just like when you get Novocaine or lidocaine in your jaw for a dentist. You know how you can't even feel the inside of your mouth for an hour or two later? That would be what would happen to your heart. Now, if you can't feel it, it's numb, it's not going to get any signals from your brain to beat, what happens? You die. So lidocaine is a very, very sensitive drug that we have to monitor very closely, okay? It increases the strength of the impulses. So if they're too weak, like this one was coming through, real fast, and I have no problem getting that one, when it numbs these up, it realizes that it may not connect, and it's a real weak impulse. And so it will help connect them, but just not as many. So instead of having all these impulses coming down, lidocaine numbs it up and makes just a few, but the few that are there are very strong and complete, so that you slow your heart rate down, but you still have a good, strong beat that's going to get that blood out. Okay? Now, adenosine is the other one that we talked about that's pretty stout. I would definitely know these three, because these are the ones that will kill people. All of them could, but these definitely would. Adenosine is the one that stops the heart for several seconds completely. Remember? That's the.
You try to use it right.
It just stops the heart, and it lets the heart just sit for a minute, rest, almost like a computer, and have to reboot it. Right?
Is it very often you have to restart the heart yourself?
It just depends on how healthy the patient is. If they're a healthy person, which a lot of them are not, because they've already been in AFib or flutter for it's a chronic thing.
Then they kind of expect
Yeah, then you always have everything ready in case it doesn't. Yeah, you don't ever give adenosine without having a crash cart ready, because you expect it not to. This one's the one that stops the heart completely, so that I can recharge. If they have AFib or flutter, AFib or atrial flutter, where the top part of the heart is not working, it's just quivering. It's beating, but it's not really being effective. It's not in sync with the rest of the heart. Then we give this when it's to the point where they might pass out or they become super symptomatic. This just stops it so that it doesn't work at all. And then it starts back in sync.
And it just starts back?
Oh, sorry. I was more like, how does it stop it exactly?
It just blocks everything. There's no electrical impulse to that. It blocks all those receptor sites.
It's like fluttering and stuff. To understand what if it just like flutters.
Yes. Some heart can flutter for lots of different things. You can have electrolyte imbalance, like if you're on a diuretic and you've lost too much potassium. So now instead of all these having that normal balance in your cell, you've got too much potassium out. There's no potassium. It all got out with your urine. Then your cells are out of whack. You have an electrolyte imbalance, and so that can throw your heart into irregular. It could be hormonal. It could be stress. It could be illegal drug use. I mean, anything can make your heart float into
Well,
that.
I had that one time where it was just like on and off for a little bit, and then I went to the doctor, and I mean, he kind of just, I thought maybe it was like the rhythm was off or something, and then so he related it, he said it was hormonal.
Hormones, pregnancy. I mean, there's tons of anything that's going to stress the heart can do that. When we give this one, as if it's to the point where they've been like that a long time, and now they're symptomatic. Like my friend climbed a flight of stairs and passed out. She had been in a state of flutter for a year, and she wouldn't go get treated. And so eventually the heart gets tired and it just stops. And that's what happened to her. It just collapsed. And then when they put her on the leads and saw her rhythm was all out of whack and nothing else was working, they gave her the adenosine to stop it. And then hopefully your patient comes back onto a regular rhythm.
So I have a question. They're already like passed out or whatever, you just give it to them, you don't need like a consent or something?
If they're passed out, they want you to help them. Wouldn't you? Or do you want me to wake you up first and then say, hey, can I save your life?
What if
Just in case.
What if you don't save my life and then my heart never comes back? Then that's
I've
kind of
tried, and you're protected as a nurse under the Good Samaritan law. If you didn't do it, you would be liable for not helping because you're trained. You're a trained professional, and you should know what to do with CPR at the very least. So then the family says, hey, you were a nurse and you stood there and watched her die. I'm suing you because you're a professional and you had that knowledge.
Okay, maybe I'm thinking too much into it, but okay, it stops the heart, and then what makes it start back? Just it does.
It
or you have to
repolarizes. It gives it time.
charge
Gives itself
it to-
time to recharge and get back very short life. And then if it doesn't, that's when you have to push the other drugs like adrenaline or epinephrine to bump it back up, to get it fired back up.
Well, don't
That's
you
what
got
I
an
would-
AED on
So it
them
only
when they
lasts
do
that
the
cardio,
muscle?
you cardiovert them.
Right, that's what I'm asking. Like, do you have to shock it back to?
That's if they don't wake
The
up right.
the shocking is for the heart's already like this. People think that the shock is to start it back. The shocking is for when they're out of rhythm. Their heart is beating, it's just out of rhythm. You shock them to stop it, to flatline them, and then the heart naturally fills back up. Each cell repolarizes and says, "Oh, I'm supposed to do this," and it starts beating.
Okay.
So the shock is to stop it,
Okay. So
and then we push meds to start it, adrenaline. But cardioverting is a little different from the shock. That is something that tells this side of the heart to start, and this side is like putting spark. What are the spark plug things on a battery? Kind of something different.
the big cables.
Yeah, jumper cables. There you go.
And she speaks.
Does that make sense? Just know that adenosine is very potent, and you're only going to use that in extreme cases, and you better have somebody with it that knows CPR and some crash cart, all that kind of stuff. Okay. All right, and then our beta blockers. There's our laws again. Remember, they're not only a dilator, they're used for this too. They can stop this dysrhythmia, decrease the heart receptor sites, the beta receptor sites of the heart, and then closing that response to the epi and norepinephrine. So they're blocking it so that epi, which is going to speed me up, can't get in there into each cell. And that's what helps me get back into my rhythm if I'm already too wound up. Those are ones you're going to take on a daily basis, not necessarily for an emergency sometimes. There are some that you can push in an emergency, but we try other stuff first. Okay. What's the half-life on adenosine?
Adenosine?
Short.
10 seconds.
Oh, 10 seconds.
10-second half-life. That's why we push 3 doses.
For 30 seconds.
You
Adenosine?
let the heart come back before you push the.
If they're not beating, you keep pushing.
That's why it's 10 seconds.
Yeah, 6, 12, and 12. If they don't come back, then you're going to try their stuff. This is other meds you can give. And then just start CPR.
Don't try that wood.
Their stuff.
So there's other stuff.
Oh.
Other stuff you
Hey,
can
you
try.
don't try that stuff. I'm like,
You're obsessed with butt and stuff.
like, don't try their stuff.
You're just the only one that thought
Yeah, because when they're dying, that's what I'm interested in. So yeah, you're gonna try other
I
stuff.
thought it was like a hormone.
It could be. I am desperate. Not that. So it's 10 seconds, right? And then that's what we give 3 doses. And then this is the one. Remember, my friend said she was so anxious and nervous. And then, so sometimes they don't want you to ever do that again, but you can give them Valium with it, all right, to help them if it's a controlled cardioversion. Eventually, these people are going to need something to help keep them from going into AFib and flutter. What do you think it would be?
Anti-dyspeptic.
Pacemaker. Eventually, that's what my friend would do. She's not 40 yet. She's like, I don't want to go through and get a pacemaker. I'm not even 40. And I'm like, but you need one because you're falling down
I had a friend in high school.
You died at the first second.
in the strike parking lot. Do what?
I had a friend in high school. They did get a pacemaker thing.
Really? Was it congenital or born with like a heart defect or?
It was, yeah, he had, was that like 4, I guess?
Yeah.
I remember, so he had, like, good Christopher.
So you're giving 3 doses in 30 seconds?
It's fast. It's a fast push. And then, because they're dying, so we try that.
It could be a minute and I'll be like, it's all right.
And then when they come out of it, like they're real sore and they're really upset. So sometimes they'll give them Valium to help them keep their nerves down. All right, let's take a break and then we'll go on to the next.
Remind me.
I need to check fact check that.
When I get on that website, maybe they're home watching her. You'll be like on YouTube. She's gonna play with my stuff too.
Yes!
Gross. And this still isn't working. I talked to Misty and she said it's something you're trying to drop on that pick up today. It's not the code, it's the, we're not registered. It's the code words. And then we've got to go and put our name and name in it. So it's tricky. Dave pointed that it's okay. One of the guys was like, February beer day. I want to get it back. Yeah, that's it. What's it today? Well, no, the code works, it's just saying that once you, it allows you to put your information in, it says to not determine eligibility. So the code works, and it pops up the box where you put all your info in.
It hasn't expired, it's just a T-bond is not saying no.
Yes, right, it's saying we're not registered.
I'm gonna call them, and I'll fax it again, because that's how they roll down there. Get ready. Wow.
Did you want to take off the, saver?
Oh, I thought you meant the time that it ends today, I'm sorry. How do I, well, it's not on here, that's why, because this is,
It's fine.
you have to take this, you have to unhook this for it to come up here. So when class is over, I can hook this back up and then we can figure out how to do it.
Oh, okay.
This is not working right now because it's going through the projector.
So
this is our
the
screen.
computer screen is here, right? You can still do it over here.
Well, I have to shut my, won't I have to shut this down?
No.
How? Don't mess me up. I mean, this is old technology.
I drink, this little smoothie. It was like this big.
Which side were you on?
I don't know. Let me see.
No, you were there.
You were here.
Chat number 8.
Number 8, okay.
Now, what did you just click?
And show.
End show. It was cold. They need to change. They need to flip. Yeah, it's cold in the back here, and they need to flip to the front because it's hot up here.
Oh, they
Our
get cold
vent-
back there?
Yeah, it is cold. It's like 5 degrees colder. This vent does not work up here. Like there's 2 vents up here, and nothing comes out of them. Y'all need to flip to the front of the room. It's 100 degrees up here.
No, we're married to BC still.
Yeah, we're married.
Oh my gosh.
I mean, Freeman said not to, but it happened.
I know, y'all are territory. Every class is that way though. They like get in their spot and they don't want to move. I've had people fight over spots.
It might
We had
happen.
one
You
episode
have-
one day.
That one girl was about to get.
Sam was mad because one girl got her seat.
Who did?
I was mad because
Who got your seat?
Diana, she ain't here no more.
She took it and the Lupe
It was
gave me his seat, so I could
hilarious.
sit still right here, but then I was just
That's
wrong
how we
because
became
I like
blocked.
no one to sit in front of me right here. I can see everything. So the rest of the day I made little comments to her.
I need to go get
I'm
something.
lost
Are you
without
gonna
staying
lose
beside
me?
me. Never said here again.
We still have time, right?
She's in jail.
She's gonna post it on Facebook.
Oh.
Are y'all friends on Facebook?
I suppose we are.
Who's Robertson?
I think she sent me a friend request.
Yeah. What do you think her stuff?
Yeah.
Keep working on it.
Okay.
I creeped on her. I saw her photo.
Does anyone know what happened to her?
I know she was going through a bad court case.
I think you're the only one that's on our friends list on Facebook, so you might need to ask her.
Oh, Josh told me that she was going through a bad court case, a bad child custody battle.
Oh,
really? No, I heard her talking one day. I wonder what her name is.
I wonder if she was on crack.
Shut up. She was, or she was coming off of it, because my grandpa calls those a liar.
Either she was trying to get off or she was.
Ruin your jaw like that.
If I'm going through a custody case, I'm not smoking crack. I'm in the
You have it?
just
I don't like the feeling of being high.
She was like, the guy had showed, I took her to like a storage or something.
It's not
and was
working.
like showing her how to smoke it and stuff. She's like, didn't know she was only doing it to lose weight.
I ended up in a crack house one time.
Did she get a massage in it? She's crazy.
I never liked drugs.
I think I overextended. Sorry.
Like he's the one in charge of like
Taking me a while. It's been a while since I've actually had this.
yeah.
Try.
Like, you know, like if something goes bad and you're gonna like get stuff stolen. You know, yeah. I had to pay rent and stuff too, so it's like a rent house, but yeah.
It's a cute jacket.
How much do you charge for your
Needs to cover more, but I have a hard time finding things that. Got a phone up here. They just have some really cute jackets. Well, you know where I go because I didn't have any real clothes. I've always worn skirts. And so I went over to, it's next to Plato's Closet, but it's like the mom store. So my daughter goes into Plato's part, and I go in the, and they have, that's where I got this, and they have like work clothes, like huge, like office clothes or bank clothes or something, and people sell it like crazy. It's where's Plato's Closet? It's right down here on 50th, right next to where the housing store is. Yeah. And it's right next door. That I want to say it's not.
It's
right
on the
away, but
left-hand
it's-
side.
Yes. Oh, okay. They have really pretty. It's for the mom clothes. Is what Carly calls it. She wouldn't even go in there.
What is it called?
But it's right next to
Style?
Plato's. What's that store?
Encore
next to
Style.
They have cute purses for dirt
They
cheap.
had a bunch of nice
Lots of
shoes.
shoes. I found a good pair of nursing shoes in there, like those the clogs that are really good. Oh, what else I got? A bunch of just jackets and sweaters and stuff. They're like $200. Yeah, I can't pay if I don't make any money on there. I don't need a lot of clothes because on the weekends I wear sweats.
Man, I need to have you sit down on like.
What are you doing?
They have nice
Look at her
clothes.
settings.
But if you
No,
and
I'm
they'll
trying
buy
to
it
find the time up button thing. Can you actually show me? Because it's been a while since I actually had this.
I thought you knew.
I
Jacking me
knew.
up.
I know.
Are you recording right now?
Yes.
Yeah.
They sell big people clothes.
Hurry
Yeah,
up.
that's what Encore Style has the bigger ones, but Plato's Closet has the
Control
smaller.
panel.
Don't let me like that. I'm working on it. I'm listening to them.
C.
I'm about to start working.
Oh, goodness.
But last week I made bags.
See, like I said, I'm about to.
No.
And I got this thing.
Well, see, I've always
So I
been big.
started.
I've always been big. In high school, I lost 100 pounds, and I gained it back when I got to college. I want to lose it again. And
Do this every day.
But this is my last week of eating bad. On Monday, I'm going to start.
What?
Last week of eating bad. Monday, I'm going to start it.
Thanks, Gilbert.
You know how many times I said I'm gonna do that on Monday?
Meg, is that this place?
I started on Saturday for one day. I woke up and I was like, I'm not exercising myself, but I'm at home.
It's not this place. It's probably the screen.
Well, that's what I've always
It's actually the lock.
Even though I've always been always
What are you doing? Change the settings?
like I know
All the problems from my family medically that's coming from work.
Let's do 45 minutes.
1 hour, so that way she knows it's time to go take a break.
Damn it, people.
But you should try it.
I'm gonna do every
Okay.
day as a piece.
That's it. Thank you. Okay.
Well,
Push the way.
I don't like him. I don't like red meat.
Well, what are you gonna do the rest of the day?
For each meal. For lunch.
Yeah, you're gonna have to.
I don't think I did carrot and chicken. Oh, I love salad.
Thank you. You rock.
There's a lot of things to do. I made brown chicken.
Ooh, I love turkey.
Did it work?
See, I don't like the other meat.
We'll change it to
Oh,
an
yes,
hour.
for me. I don't like steak.
So that way,
For 45 minutes.
Okay, good.
To an hour.
an hour, so that way you know when it's
I
time to
like
take a break.
brown turkey and white chicken.
Oh, yeah,
Shut up.
That's my issue.
I try to watch the clock. Well, it's just now an hour. I do pretty good because I get tired after about 15 minutes. I can tell it's time to take a break. My throat starts getting scratchy.
You get started after 5 minutes.
And I get the blank stares. I know how to read your room.
I guess we can do this during our next break.
It's
not that
still
I'm
not
excited.
letting, and you're going to braveheartwizard.com, and you put in the S, and then the other one. Was it working before?
Yeah.
She's gonna. I gotta just. I'm gonna call them and keep calling. Because I've already sent that in, but I can send it again and call them and verify it. Sorry. Okay, everybody's phones back in their pockets. Not your pockets. The pocket. This pocket. Which number? Did they say something about anything? What they say? Miss Donna? Guess what y'all get to do more than well, sorry, I gave somebody. Take his head off. I'm gonna stick you at me. Good. I'm gonna get some more water. All right. Can we check on Brandon? It is an hour late. Maybe he'll be here. He can walk here by now. She's around. Or hitch a ride. I'm sure somebody would have picked him up.
Hitchhiker. He's a big old black man. Ain't nobody picking him up.
I would have picked him up. He looks like he needs help. I picked him up.
You would be in his scrub.
You see their car broke down, you know. But I did that pretty sure drunk. And so he was sitting on the side of the road, and I was like, oh, he needs help. And luckily, I guess God knew that, I was going to eventually help do other things because he didn't murder me, but he could have. And he was so drunk, he passed out. And I was like, I don't know where to take him. I don't even know where he lives, because he passed out. And
In your car. What did you do?
Take him to the police station. I don't know if I got set the man up. I don't know how to do it. What did you tell me? What did you tell the police? I just told him, I was like, he was on the side of the road and he looked like he needed help.
Well, she had already had him in the car.
So did they take him? Did they hold him up? What did he say? No, they were like, they looked at me like, why were you picking them up? And then it took me a couple of days to tell my parents, and my mother was furious. But you don't think like that when you're 17.
You just want to help somebody.
Yeah. You're so
I
naive.
picked up a lady.
Supposedly help people that's just God see God.
I picked up a lady.
You gotta be careful now because people will hurt you.
He made me put on the side of the road one day needing help.
And I'm going to call somebody.
Now, and then we didn't have sometimes, now that's what I would do. Like, dude, I can't, and after I had kids, you think different too. Like, if I get me out, this is so I would just call and say, hey,
This is Texas. Everybody in Texas should have guns, so therefore.
I just ain't going to pick him up because he might have his gun too. But he got
just gotta get into a gunfight in the car. You know what? You can't, and I was like in a little country road. I mean, looking back, it was crazy. I was I guess they did, but they didn't.
I mean, they always know, but some kids where I know we're in hospital. Somebody needs help. Somebody got to it ain't got to be something I have. You never know.
I've done so many crazy things. I look back on my life.
I mean, if it's your time, you just make me stay.
Hitchhiker stories. Hitchhiker stories. We got one. What we got a hitchhiker story?
My friend made me so mad. Okay, so I was supposed to be going to church with her, and she goes to Tech, right? And she's like, she goes to this church that's like close to Tech, where there's kind of like it's in downtown, so it's not in that great of a.
Yeah, it's a little sketchy.
Yeah,
Some
it's a
places.
little sketchy over there. But anyways, went to church with her, and this lady was homeless, and she just kind of always goes to the church a lot and stuff. And but she's not really all there in her head, and she's always begging people for money and stuff. And you could tell she was on something. So my friend took it upon herself to say, "Oh, let's give her a ride home," and this was my car. And I was so mad. I was like, "Why are we doing this?" And I of course there was another girl that was going to take her, but we didn't want her to go by herself. So I said, "Okay, we'll just all go in my car and we can take her." And it's just so annoying, like just going home and stuff, like trying to take her home because she was in the car. She was asking me for money. My friend was like, "Oh, keep your purse up front, keep your purse up front." I did. I went on the
Take a ride with the windows down, going.
A lady I will, but not.
and then on top of that, she was like, "Oh, I feel like I need to throw up," and I was so mad. I'm like, "Really?"
I was thinking, hepatitis, not my car. No.
No, and she wound up throwing up, but she wound up, somebody rolled the window down
Oh.
and she threw up. It was just the worst. It was the worst.
Okay, my grandpa, I'll keep this short. My grandpa is old. He's like he's like 85 at this time. Why he was in Lubbock at Walmart, I don't know, but he was at Walmart and he picked it. This this girl needed a ride. He took her. Well, he wound up taking her somewhere like over there on the east side, and she goes, "Can you just wait for me?" And he was like, "Yeah, sure." So he waited, and this cop came. Yes, this cop came, and he told my grandpa, "What are you doing over here?" And you're with the well-known prostitute, and you're at a crack house. And my grandpa was like, "Yeah, he can barely speak any English." And he's like, no, I don't know, whatever. I was just giving her a ride. And he goes, "Sir, you need to leave. You need to get out of this neighborhood right now." So my grandpa took off, And he went home and he told us, and my mom and them were so mad at him. And he was like, I was just trying to help her. She was a younger one. She was one of my granddaughters. And my mom was like, well, your granddaughters better not be prostitutes. Getting cracked.
It's hard to be a good Samaritan because people will take advantage of your niceties, won't they? They are. But speaking of that, from a nursing standpoint, you do have the Good Samaritan law that hopefully will protect you. If you're trying to help. They're not even going to stop. They're not going to slow down. You're not going to do a drive-by today?
There's so many people that scams and my nanny's with me. But, I got a chance to whip her ass and shoot her ass up. There's so many people that good plan. Don't worry about people and not help them.
Yes, you do. I got 4 kids I got to be here for.
The Lord just will protect you.
No, girl.
I know you're going to have faith.
What is that?
That was him that told you keep going. Don't even stop. Okay, but that's different. It's different if you be like, Lord, I'm about to stop and help these people, and then you just be like, oh no, you get a bad sense. Okay, keep going.
Okay, so anybody that breaks down, call Asia. Anytime, not a day. Asia will get your number later.
What about them people that sit out at Walmart and tell these sad stories months at a time?
But you give it to them.
I don't care. I give them their money and go on about my business. I don't care if they go in the store and buy up a beer. I give them enough to buy 2. I'm still going to get my blessing because it doesn't matter what you do with it. But as far as people, I'm not doing it.
It's really not good to give people you don't know. Because like that woman that was in the saying, she really could have told
We were like,
at least it
I
was
hope
3
all
of us.
3 of y'all didn't let y'all
Well, one time I was working at Burlington, and we wouldn't get off until like 12 or 1, and this man was walking, and he knocked on my window. He was like, can you give me a ride? I've been walking from Brownfield or somewhere, and I'm like, I had my taser. I'm like, empty out his pocket. And he like took everything out of his pockets. He had a knife. I'm like, oh my God, this took off real fast. Like,
The knife.
He's like, oh no. Dad got off the Brownfield without a dog and a knife, and still no ride.
I'm never asking her for a ride.
Oh my gosh. Y'all are a hot mess. I think, did we get to this one? I think that's the last one on this rhythm. We know quinidine, syncope, anybody that's having these kind of drugs are going to be risk of fainting and falling, so we know we're going to be careful with them, right? Okay. So let's do something first. I'm going to wait on that. This is going to be fun. I work with elementary school
You're not going
age
to make
kids.
us run.
No running. No running. So the first one is just think of these as vessels, okay, blood vessels. All right. You're cold.
I can't decide if I'm cold or
Y'all need to bring coats because I'm hot natured.
My hands are cold, but my head is burning up.
Right. And then we're gonna do these are. I want you to look at the diameter, okay? This is a visual.
I didn't. I went. I wasn't about looking at my mouth. I wouldn't do that. Yeah, that's ridiculous. I would never do that. It's Dr. Batman. I can't.
Alright, so I want you to think of this as a blood vessel, okay? The other one, the brown one that I'm coming around with, not a coffee stirrer at all. Because I'm not on a budget.
do it. Alright, blow through the brown one. Breathe it in. It's a lot harder, right? Why do you think that is? It's resistance, constricted. It's a narrow blood vessel, right? So as hard as you're having to push air to that, it's the same thing your heart's having to do when it's time to push against that high blood pressure, okay? So when you have that, it clicked in it. Push that, push air out. That's what your heart is trying to do all the times when your blood pressure's high. Now do the red one again. So much easier, right? So the brown one is what? Vasoconstricted. And the red one is vasodilated. Look at the difference. And which one do you think is going to be healthier for you? The red vasodilated. Because you're going to get more blood flow to all that tissue, right? Okay. Now, we're talking about atherosclerosis and hyperlipidemia. Put it back in your mouth. Hyperlipidemia is too much cholesterol in our system, right? In our vessels. This is like, to me, a visual of something tangible, like a vessel that's atherosclerotic. It's stiff, and it's crunchy and crusty, and it's thick. There's not a big, patent, open vessel, is there? This is what happens when you smoke and when you have cholesterol in your system. Over time, it's going to dilate and constrict, and so it gets hard and crusty and stiff, and then we end up with constriction.
How much time? Oh, I should be good.
2 minutes off the life of every cigarette. So start counting.
I should be dead right now.
Right?
What is that really?
This is a
Michelle's
marijuana
dying tomorrow.
Yeah. You probably knew that though, didn't you? Hey. This is Dr. Little, everybody. Hello. So we're talking about atherosclerosis and hyperlipidemia. So if you have this is what is going to happen when you have too much cholesterol. It starts getting big, sclerose. If you're a smoker, those vessels are going to cramp up and they can't dilate and constrict anymore. Okay. So now you've got your red straw, which is what we said that was? Vasodilation. You got your brown one, which is what? Constriction. We already said it's a lot easier to push against the dilated vessel, right? Okay. Now this, pay no mind, this is Robertson's foot cream, not at all. Just kidding. Just dip this down in here, okay? This is going to represent cholesterol, okay? I just bought this. It's really not
I have to do that. I got that.
I want you to dip your vessel in there. You may have, if you got a little excess, you may have to leave it off. Where's your vessel? This is represents cholesterol. So after I've eaten all those cheeseburgers we talked about, you didn't get enough cholesterol? No. Extra healthy cholesterol. They have the omega.
Great.
The butter and all those are extra stuff. Because eggs are protein. Now hold your cholesterol, your vessel that has all the cholesterol in it, up to the light and see if it's still paper. Can you see through it? Yeah.
No.
If it's completely clogged, you're probably going to need some stents, can see through it, and changes in lifestyle, right? So this is what happens when you have hyperlipidemia. Your vessels are going to be clogged with all of this cholesterol. Which was remember from yesterday, which one's our good cholesterol? HDL. Which one's our bad cholesterol?
LDL.
And so we want to have more HDL because they help clean that out. And so
This is LDL, right?
yeah, so you can take all of these type meds that you want, but if you're not changing your lifestyle and you're not going to try to eat healthier, you're still going to get clogged up eventually. You know what I mean? All meds your body gets used to, and eventually you're not going to be as effective. Okay? Oops, drop your cholesterol. The neck and rub it. Alright, so that's just a real big.
You said it smells like chocolate?
Yeah, it's paperback. So So what we give, if this patient has all this, we're going to give them anti-hyperlipidemics, right? Tell me one, who remembers the most common group of anti-hyperlipidemics? Statins, good. Those are supposed to be the most effective. They cost a little more, remember, but they work. There's some more studies that are coming out now because our book is a little bit behind, but there's studies now that are saying they're not even as effective. Why do you think that is?
Because you've used them so much.
It does you no good to take a pill. You can wait. If you're not going to do lifestyle modifications too, okay? The pill can only do so much. Meds, okay? So the statins are really good. They're our first choice of treatment that usually the patient is started on. But what are the things that we're going to need to do to teach our patients to do? Altering your diet, a little more healthier. What else? No smoking, exercise.
Smoking has nothing to do with the cholesterol.
Whatever. Keep telling yourself that. Okay, diet, exercise, meds, no smoking, all that stuff helps to make a better, healthier body. So we teach our patients that. What else am I going to be checking for if my patient's on these anti-hyperlipidemics?
We are going to be checking for the
What was the test?
cholesterol level.
Yeah, first I'm going to do it. Am I going to have them come in and do their blood work after they've just eaten a big breakfast?
No.
They have to fast. So we're going to get fasting cholesterol levels, right? Fasting blood work. And what is the total cholesterol level supposed to be? Less than 200.
Now 150, right?
Right, they're narrowing it. They won't let us eat anything anymore. Okay, and so then also, what am I going to check though when I'm taking statins? Remember, they're toxic.
Your liver.
That liver
They're
function
hepatotoxic. So we're going to do a liver function test because we want to make sure that they're not burning us out. Okay, liver function test on all statin drugs. Okay, those are on page 215 if you didn't get them yesterday. So let's look at this thing, the statin. Yeah, they all have that statin at the end. That's a good way to remember. All right, 215. Yeah, 215. There's a table at the top that says common anti-hyperlipidemics. I hope you marked that from yesterday. Okay. So that's the first group of anti-hyperlipidemics. All right, those are our statins. What's the next group?
Fibric acid.
Our fibric acid derivatives. What are they going to do?
Lower the triglycerides, increase HDL.
They lower that triglyceride, but then they help us get that better, a higher level of HDL, the cholesterol that's going to be good for us and help us clean out some of that other stuff, the bad stuff. Okay. The bile acid sequestrants, they're excreted out in our bowel movements. They kind of are like a sponge. They can help get it out that way. It's excreted. Okay.
Yep.
And then niacin is the last group. They're effective at lowering the LDL levels and increasing the HDLs. That's how they work. Because remember, we don't want the LDLs because they're the kind of lazy ones, remember? So we want those HDLs. They do all the work. They're the vacuum cleaners. Okay. What is one of the side effects, though, of the niacin ones that I have to watch for? Yes, they have the flushing. If they take an aspirin when they're on a niacin anti-hyperlipidemic, they might have that flushing sensation, okay? All right. That all starting to gel now and make more sense? Okay. So when I have these patients that are on this stuff, these are the things I need to watch for, right? There's always drug interactions, but especially if they're on anti-cholesterol med. Remember yesterday we talked about there's one thing that I want to be really, really careful of when I'm looking at my patient and getting their H&P. When I'm bringing them in, I want to get a good assessment on them and look at their list of meds, because if they're on one of these in particular and they're taking a cholesterol med, I need to be very, very careful, right? Which one was it? Anticoagulants. Because if they're anticoagulant does what?
Ginger blood.
It's helping thin our blood. And then I'm taking a cholesterol med that's going to help do what?
Ginger blood.
Yeah, in essence, it's getting rid of that thick cholesterol, so it might thin it. So it's going to amplify the effects of that anticoagulant. It's going to make it dangerous, maybe too dangerous, too thick. So I definitely need to watch for that interaction, right? What else can they do, these anti-hyperlipidemics? Or something else I need to watch for? They're going to interfere with our vitamin absorption. So if I'm a little elderly person or someone who already has GI issues and I need every vitamin I can get, and I'm taking this cholesterol med, it might cause my vitamin A and D to not be absorbed. Okay, so that could be a vitamin deficiency that's brewing. That could throw some things off. All right. And then what about the last one?
Constipation.
Yes. These can cause constipation. Now, does that seem like it's on a, I guess, the level of scariness? Something that's scary?
Yeah.
No, not necessary, but it is uncomfortable, right?
Yes.
And it still could end up being something that's really bad for our patient. We don't want them to be uncomfortable or constipated or eventually get a ileus where their bowels won't move at all, because then that could possibly be a surgery. So correct that. So if they're taking statin, I need to know that they're eating what kind of diet? Low cholesterol, high fiber, good, lots of water, help flush, making sure that my vitamins are all there and I'm eating things that are going to help my bowels move, okay? Now, what about when we're taking our meds, our other meds with cholesterol meds? Are they all good to just dump in a cup and take? No. What do I need to do with them?
Take them in a certain time.
Not together.
Not together.
Right? So what's my times?
An hour before or 46 hours?
Yes, an hour before or 4 to 6 hours after. That way you've got a little cushion. Because remember, if you take all of them, they're going to absorb everything, including your blood pressure or your other stuff. So you don't want to do that. Okay? Any questions on those? What is the time of day or night that we make the most cholesterol? Night shift. Yeah, 12 to 5. That's when our body is something out. So it could be good to take it at night, maybe, right before bed if they want to. Okay? If they have a bunch of other meds. So again, that's what your job as a nurse. You gotta look and see what they're taking and start helping that patient plan that, because they don't know all of the stuff that you're learning, so you have to help them planners, okay? All right. Cardiotonics. Did we get to these yesterday? No. So everybody good on what we covered up to that point? Yes. So cardiotonics, what is their function? What do they do?
The beast is stronger, of course.
So are they speeding up the heart or slowing it down? Someone's at the door. Hold on. They're going to slow the heart rate down, making it a stronger beat. Okay. So they're going to slow the heart rate down, making it a stronger beat. And what that does is help, when we slow it down, gives it time to fill back up, right? Remember our little picture? Gives it time to fill back up and then contract, making what? More cardiac output, more efficient, right? We're getting more bang for our buck. So that's what these cardiotonics do. They're going to help increase your cardiac output by contracting that strength, slowing it down, and contracting that strength or force of the contraction. Okay? They're used in usually patients who have congestive heart failure, or maybe they have a rapid or just an irregular heart rate, like an AFib patient where the top of the heart, the atrium, are not in sync, they're fibrillating, they're not really beating a solid beat, they're just kind of quivering. A flutter, where it's a little more dangerous. The top, the atrium are fluttering. They're still not an effective beat though. And then they could be having PVCs, which is just a real big, sometimes if you've ever felt a PVC, it's like somebody's a sudden stab pain. You know, you're just like, take your breath away for just a second. It's just a random irregular heartbeat every now and then. So sometimes they'll give those patients who have those that are more frequent PVCs, they'll give those meds to those type patients, okay? Because we certainly don't want it to progress into an occasional PVC, into a whole line of PVCs, because that's when you're going to have to get the electricity out to shock them, like we talked about earlier. Okay. So these meds are plant derived. There's one that's real common that we give a lot. Anybody remember reading about it? It comes from a plant. Digoxin. It comes from the plant Digitalis. Okay. When we give those, we have to be really, really careful. Okay. Dig is one of those things that you have to tweak. Make sure that it's not too much and not too little, because if it builds up in their system, they can become dig toxic. Dig toxicity. Okay. So how do I know month to month if this patient is taking their meds correctly or if it's too much or too little? How do I know? You have to draw labs. You have to draw a dig level. So this little patient will come in, usually the physician or the nurse practitioner will order it, and if it's a new dose, a new med, they're going to do it more frequently. But once they stabilize, sometimes they can come in less frequently. But they're still going to need that level checked because you can become dig toxic. Remember, it's slowing the heart rate down, right? So how would I know if they're dig toxic? Besides getting my work, what's a symptom I might see? Fatigue, for sure. Because I've got a slow heart rate. What else? Dizziness. Dizziness. Why? I slow my heart rate down. I'm not getting that blood pumping as much. But what else?
Vaccinations.
What's something measurable that you're going to be doing to every patient? Vital signs. Vital signs. I'm going to check their pulse, right? In your book it talked about there's a number that we go by. Standard rule. If we check their pulse and they're on dig, if it's a certain number, we hold that medicine. Yes. If their pulse is 60 beats a minute or less, we hold that medication. Because we don't want to, they're already 60, which is, it's considered slow. And we don't want to give them something that's going to slow it down even more. Maybe they've become dig toxic. Maybe their body has just absorbed all of it and it's holding on, or they're not excreting it out anymore. They're not getting rid of it in their kidneys. So I definitely want to always, always, always check it. Now, am I just going to check their pulse on their arm? No. How do I do it? I use my stethoscope and get an apical pulse right there on the chest and count it for how long? 1 minute. A full minute. Not this 15 seconds times 4 business. Not a shortcut. I need to listen for an entire minute. Because if they already have an irregular heart, I could count for 15 seconds and that might be a slow speed. Then they have maybe a rapid run or something like that. So you listen for an entire minute, okay? Everybody got that one? That is just a standard rule. Make sure you know that. Before getting Digitalis or Digoxin, I'm going to be checking for the apical pulse for 1 full minute. Listening with my stethoscope. If it's less than 60, what do?
Stop the med.
Hold the med and check with the provider so that I can make sure this person's, going to need something different. Right? Sometimes you can just hold it for a day, or they'll draw a dig level. Sometimes they have to change it all together. Just depends. Okay. Now, there is digitoxin and digoxin. Those are 2 different meds, so make sure you don't get those mixed up. There's a lot of drugs that can interact with cardiotomy. So on page 216 in your book, it gives you there's a table there that says the signs and symptoms of congestive heart failure, which is the people that we're going to be giving these meds to most of the time. And then there's a whole section right there that says drug interactions on page 216. There's a lot of them. You see that? Beta blockers, calcium blockers, calcium channel blockers, verapamil. All of those are going to be toxic if you give them with dig. Okay, so those are something you need to remember. 216, it says drug interactions in between those orange bars. This is a real common one, so chances are you're going to have a patient with this. You're going to have several patients with this later. Okay? We always check. Don't take shortcuts on this. Okay, does anybody know what the therapeutic level of dig is? We've already said, well, we're going to draw some blood, but what if I draw it and I don't know what the number means? Is that going to be any good? What's the number? Y'all need to start learning all your labs now so that when you're at level 4, you can just rattle them right off. Okay.
0.5.
0.5. Yes. 0.5 to 2. That's where we want them to be, in that range. That's not a very wide range, is it? So that's why it's so easy to become toxic on it. And so if they are toxic, this is the therapeutic range right here, okay? Now if it's toxic, that's greater than 2.5. Yep. So if I draw it, I notice that their pulse is low, they're being dizzy, disoriented. I don't know, just something's not right with Miss Smith today. You know, she's usually very alert. She's usually very upbeat, ready to go. Then I go in and I see all these symptoms, check her pulse, and it's low, and then the lab work comes back and it's 3.5. We definitely need to work on her, right? Okay? So that's why labs are important. Because if you don't know what they mean, then they're just numbers to you. But if you do know what it means, then it's going to tell you how to help your patient. Okay, so know those. If they are toxic, the doctor or the physician or the nurse practitioner might order Digibind. That's kind of like the antidote. It goes in and it helps bind chemically with that digoxin that's floating around in their system, making them too toxic, and then that helps get their level back down to normal, okay? Now, is this somebody I should just shut the door on and say, good luck, I'll see you at 3 o'clock? You know, what am I going to be doing? Yeah, a lot more frequently, right? Because now her heart rate's low. I don't want to go in to have her lunch tray and she's blue. I need to go check on her a lot more frequently. Any questions on those? The cardiotonics? Sometimes they'll also do, if they're toxic, they can do an NG tube. Have y'all done that in skills lab yet? Yeah. Oh, they're fun. You put those down and you can give charcoal. It's like a, not grilled charcoal that you got at Walmart. It's a special kind of mixture, and you can put that in their NG tube, and it helps absorb some different things. We can use it for a lot of different meds. And then they can pull that out, or we do gastric lavaging. Like if it's just recently happened, they realize they took too much or something like that. But we don't want them to vomit. We don't want them to say, hey, you doubled on your dish today. Go in there and gag and make yourself gag and throw up. Why do you think that is?
Absorbs the skin.
Think about your cranial nerves from A&P that y'all are talking about. What happens when I throw up? What nerve am I stimulating?
Vertebrae. No,
The vagal. Yes, vagal nerve. There you go. You were close. Vagus, vagal, same thing. What happens in vagal stays in vagal. So they're going to stimulate that. And that's going to drop their heart rate even lower, right? Because remember, it drops our blood pressure and our heart rate when we stimulate that vagal nerve, that 10th cranial nerve. So we don't want them to throw up. So we put the tube down and we try to help them that way, or we give them the Digibind. Okay? That makes sense? All right. Now we're getting down to our antihypertensives and our diuretics. Whew, this has been a long chapter, hasn't it? So I gave y'all these handouts today with your antihypertensive. They're little cards that I got out of a little book, and I just made a copy of it. On the front is a little easy picture, kind of like the handouts that I usually give y'all, but on the back it has all your information on there. Okay, so the first page is antihypertensives. What is an antihypertensive's function? Lower the blood pressure, right. So there's different kinds. Remember, some of our drugs, they're not only going to slow the heart rate down, but they help to lower the blood pressure too. So we can use them. They might look familiar. We've already seen them and talked about them when we were talking about our heart rate, right? One of the other things they do, instead of having that little brown straw constricted, and then we give the vasodilator, which helps open up, and now it's antihypertensive, and are open. We can also give a diuretic. Think about this water bottle. If it was full of water, pressure is going to be a lot higher, right? There's more volume in it. If I emptied out some of it, it was almost half empty or a little bit less than half empty. Would the pressure be the same in there? No. What's it going to be? Less pressure, because I have less volume or less anything pushing against that and making that pressure higher, right? So the same with your blood have too much fluid or volume in your system, that's going to run the pressure up. Just like, hey, I know y'all are young, but back in the day when kids played outside, we would go and stick our finger in this water spigot. You know how the hose comes out of the house, and we would stick our finger in there and turn the water on and see how long it took before the pressure pushed our finger out. We didn't know what that was. We just thought it was funny. And so we were weird. And so look at that now. That was the buildup of pressure, right? And it pushed our finger out. Or if we had a garden hose, we'd crimp it and make it, higher pressure so that it would spray out. So the same concept. When you have too much volume and you're holding it and it can't all get out, the pressure's building up, right? So what we do for our patients that have hypertension, we can give them a vasodilator, but sometimes they can get a diuretic because that's all they need. They just need to get rid of some of that extra fluid. Okay? So that's where these come in handy. Diuretics help. Their whole function is to get rid of that excessive water or volume, and that helps reduce your blood pressure. Okay? But we know water is lonely. It likes to go in with its friends. It follows people. What's one of the things that water follows?
Sodium.
Yes, sodium. It's a plus, so it's a partier, and water wants to be clinging on it and go with it, right? So water's always going to follow sodium. What's this one? Potassium. And potassium. Good. Water is kind of that third wheel friend. Just hang out. They follow you everywhere. Okay. So what happens when with some of these diuretics, when we get rid of the water, we're also losing what? Potassium and sodium. So sometimes that's okay. If I had a lot of sodium or potassium to lose, I'm good with that. But sometimes that can be detrimental. Okay. If I don't have a lot, that could throw me off. Right? There's lots of different types of diuretics. Okay. There's thiazides, sulfonamides, loop diuretics, and then potassium sparing. What do you think the potassium sparing diuretics do?
It gets rid of just the water sometimes.
They spare the potassium. They say, sorry, potassium, you're a loser, you can't come with us. And you get rid of the sodium and the water, right? And so that way you save, your potassium. Now that's a good thing if I have low potassium, but also what can happen though, after a while, I'm saving all my potassium, but what can happen? You get too much potassium in, right? And we know potassium, too much of that can slow our heart rate down. So it's a fine line with those. You have to watch those carefully, okay? What is the normal range for blood pressure? What is considered?
120 over 180.
Yeah. So what, when I get to a certain number, it's considered hypertension. This was in your book, which makes me sad because I'm really close to this number. 140 over 90 is considered mild hypertension, okay? And then the higher it goes, the more severe your hypertension is, okay? So hypertension is defined as a grade 140 over 90 or greater, okay? Who are my people at risk for hypertension?
Obese.
She knows I'm not saying it.
Smokers.
I promise I'm not picking on y'all. Yes, I am. So our age, the older we get, it's going to be high risk because eventually, remember, our smooth muscles in our vessels, they get tired. They're getting tired of vasodilating, constricted. They're tired. And especially if I smoke, they're tired. And so they get where they can't dilate anymore. They stay constricted. So our age has something to do with it. African American race has a higher rate of hypertension. No, it's just genetics. Because I ate a lot of that. I think it's just genetics. Just like a Caucasians have a higher rate of Alzheimer's. It's just a genetic thing. Males have a higher rate of hypertension. Sorry, guys. And then our family history. If people in your family have had hypertension, then chances are you are going to have it. Part of that could be genetic, but part of it could be what else? What do you think?
Your lifestyle.
What did we all grow up eating? Whatever mama put in front of us, right?
Grease.
Yeah. Mama ate it, and you were expected to eat it, and so now I got hypertension. Thanks, Mom. So, exactly. So, I think part of that's a good balance. And so now we have to turn that around and realize it could be heredity, but also it's lifestyle and choices. So we got to teach our younger generations how to eat. Okay. Of course, our smokers and our vascular disease. If you already have issues with circulation, you're going to be higher risk for that. Okay. When we're given any kind of blood pressure med, what do you think the first thing we need to do besides checking our blood pressure? What do you think we're going to be watching for? What's our highest risk of somebody who is getting a pain med or blood pressure med? What are they highest risk for? Yes. And what does low blood pressure do? What do you think it's high risk for? Orthostatic hypotension, falls, postural hypotension, right? Or we're going to be kind of woozy and weak, and we might be more prone to fall or stumble or trip. Yeah. So that definitely is something we want to make sure we're teaching them, okay? To take their meds and get up slowly. Don't try to get in a rush. We're going to watch them for low potassium if they're on a diuretic that doesn't spare it, and we're going to watch them for increased muscle weakness or fatigue. Sometimes they get muscle cramps when they're taking diuretics, okay? Because it's pulling out that potassium with it, and so they'll have cramps. Can this be any kind of med like this, but especially a blood pressure med? Is this something I can just stop taking? No. Well, I feel good. Well, my blood pressure's normal.
It's not going to be after you stop.
Why is it normal? Because of the medicine. Exactly. Your patients will argue with you up and down. I've been taking this for 3 months and my blood pressure's fine. I'm going to Popeyes. Bye.
Well, that's why.
That is not going to help them, right? You have to tell them your blood pressure's in normal range because you've been on therapy with a blood pressure med or a diuretic for 3 months. You are now where we wanted you to be because of the med. If you stop the med, what's going to happen? It's going to go right back up. So you have to teach compliance, and they do not like it. They do not like you telling them what to do. Yeah. They do not like you telling them what to do. All right? On page 221, there's a good picture for diuretics, okay? Have y'all done the kidneys yet? I think that's further down in A&P. Okay. So, this kind of tells you how these work. It gets real deep in the book, and we'll go over it in kind of a simplified version. But do you see on page 221, this looks like a yellow tree trunk with all the limbs cut off of it?
Yeah.
Yeah. That is kind of the filtration system in your kidney, okay? And so the diuretics we were talking about, they work in different areas. Okay? So the thiazides are going to work on a certain part of the kidney, and they help prevent sodium and chloride reabsorption at the loop. Y'all see the loop? It says inlet loop and then there's loop. Okay? And then some of the other ones, as they go through, they work in different areas. If they're a loop diuretic, those are the most effective. They work the best. Okay? Those are for our CHF, our kidney disease, maybe our cirrhosis patients. Okay? They work right there for loop. Now the thiazides and the sulfonamides, they have a real long half-life, so they can take one and it's going to stay in their system all day, right? But the bad thing about that is it goes in a lot of water and potassium, so you have to be careful with them. Yeah. And the loops just work the best, and they're very commonly prescribed. There's a list of all these meds on page 224 in your book of the diuretics. Okay? Are y'all freezing?
Yes.
No. Babies. Any questions on the diuretics so far? Does everybody have to go to the bathroom now? Yes. We talked about it? Okay. Alright, it's time for a break if y'all need a break, and then we'll come back and talk about the other. Go and fall out.
change your answers too.
I wouldn't have to change mine.
You might have changed your friends' votes.
Except for one, so I didn't put those stupid words out. I didn't know it had to go anywhere.
Let me tell you about my boy.
Where's the Robert?
Did I give y'all that farm, it says farm review at the front, and it has like the first page has all the definitions of what an antagonist and all that is. I thought I gave y'all that the first, this is like the basic terms at the front. If not, I
The little dictionary?
You did.
can I see yours for a second? Because we're gonna cover, I wanna make sure Gary's not, it's not, I think. Pick one. We're so organized.
I really tried it.
I had all the
you did.
basic terms at the front.
Hold up, hold up.
In our other binder, other color-coded binder.
No, it's, I don't have it. I would have it. I would have
I know you will. I can run and get some. I just couldn't remember if it was y'all or the other group I gave them.
You better not have it.
No, we got one friend, this Skip. Okay, so it'd be an A.
I'll just do it real quick.
Let me see.
I can make no copies of it.
Was it Miss Skip that gave it to us? Or was it Miss Freeman? It was, oh, I don't know.
No, I remember seeing it. I just
Here it is. Well, I'm not gonna ask Nancy. She's gonna offer.
Look at this chair.
I love that. But that's too big. It won't fit under my desk.
It's cute though.
So more.
I want one without the arms. If you see one.
Look at these. Your income tax and it, on the bar, you know, it says it's sent it to you. Does that mean you get it that day, or does that mean it's still gonna be like another 3 days?
It really depends on your bank. Once they send it through,
It'll take like a week.
then it'll process. Like,
Probably 2 weeks.
it'll say, they send it, oh, it's not, that's the only one that should get it. Once they send it through, it'll say you get it on the, say today, the 22nd. Well, it's today, anyway. Then it usually goes through today, but it depends on your bank.
Yeah, mine says that it will be sent on the 23rd, so I was just curious if I would get it that day, or if
She
it,
is.
I'm such
I
an
don't know.
income tax hater right
I
now.
don't get any, so I don't either.
you don't get any with all the kids you have?
I only have 2 boys at home that are my biologically. The other 4 I have not adopted.
So I only have one, and I got,
Yeah, but I own my own business. So, yeah, the other 4 are not mine. Well, 3 now, my 18-year-old Ashton moved out. Took her another baby. Okay, right. I didn't even cry like that when the oldest moved out.
you see your last one that moved out?
What?
You see your last kid that moved out, you see?
Ashton is one of the 4 boys that lives with me that I know.
Oh.
So he turned 18 and moved out. Hey, look at the thing. Where were you looking at those for that?
Training up on Facebook. What
What?
is it called on
Training
Facebook?
What is that?
Is it something you can trade, like,
I need a chair.
For what?
My dad.
Do they have nice couches
I want
on
like
it?
an antique chair. One that doesn't have arms that's like cloth, you know? Like a dining
My son broke my couch.
So if you see
How's your
that,
2-year-old break your couch?
Because he jumped on it and like
Don't
thought it
even
was
bother
the
getting a
jumping.
new one. Just wait till he gets a little bit
You
older.
think it does?
don't get me
My daughter spilled a lot of the nail polish on my couch.
Girl, the first
Well,
day,
see, I
my
bought-
couch is only 2 years old, but the first day I got them, my daughter squeezed out the whole tube of car mix on them, and they're suede. I'm like,
Mine,
Oh, I thought
Oh,
you
you
did
put that up with milk.
And nail
Yeah.
polish, you
Mine
need
is
to
nail
show
polish.
it.
girl, I was like, oh my.
You can get that up with milk.
And now I just gave up completely. Now they look
I
like
don't know. You never seen that big?
Or vinegar. You can use vinegar.
You understand? I just thought it covered with plastic, you know? And the grandma used
I
to
have a
do
big
it.
stain on my couch that looks like I did something real dirty and just kept it there because it's white nail polish, like clear nail polish. It does get dirty. I just cover
see,
it with
I
pillows.
got a
Okay,
leather
where's
couch
the
so I
light?
could just wipe it off.
Don't get new couches while your kids are
Yeah.
small.
I mean, I've
Well, my
done
good thing
I've
is
done
for me,
that.
they were already like 4 years old.
Mine are grown.
But I won't get new ones until she knows how to behave, get some act right in here. I won't.
Get some extra. See, like that.
We went to my parents' house.
What do you think?
But I don't know if I like that color. It's like a mustard.
And my dad was
Oh,
like,
I like it too.
he said, your son is a mess. Because my dad has a English bulldog. And my son said the dog was, playing tug of war. My son said the other place they couldn't get him out. Was playing tug of war with the bulldog.
Just have to fill the pictures. Huh? Just so it can for pictures. Oh, that'd be cute for pictures. Yeah. They look like they're in good condition when you mess.
This is us. I'm gonna have to. She's the board.
Yeah.
I wonder why I need cameras so bad.
Those kind
So
of
more
chairs.
camera?
That's
They have some nice ones at the pawn shop.
Cook about one of those,
No.
She wants to bring her name on.
those.
Oh, it's the pillow.
I'm gonna get this one. I'm gonna knock
It's the pillow that's
Oh,
for
I
it.
have a blue one.
The what?
The armadillo camera place down the street.
What is that?
They
I
sell
have
good
a
ones there? They sell good ones there? So all they sell is cameras or all they sell is
she can come back in the morning and get
I need a phone.
I charge 85
Why don't you go to the pawn shop?
and tell her that she already has
They never
her.
work when you get them from there.
You don't?
Okay, so that she can bring her hair by my house today, then I
Because
can go
when
ahead.
you go and try, when you, it does work, but when you go to get it connected, it won't connect it because it's from someone else's link.
Why don't you, why don't I?
Okay, I text you something. Okay.
Okay, that's just right.
I sell trades, that's what it's called.
I'm on two Lubbock ones.
I'm on like what?
I'm only on the baby kids free one.
Those little girl stuff that kind of people.
I think I'm in one with Martha.
What?
Did you post something on Buy Sell Trade the other day?
On what?
Buy Sell Trade?
Yeah.
I posted it somewhere on Facebook and I can never find it again. It's hard. It's not even on time. So they're my heels and boots.
Yeah. So I don't know.
What size are they?
I was gonna buy them, but oh my gosh,
What?
I might break my back.
Let me see.
They're high.
They're super high.
Are they?
Well, they're 4 now.
What shoes?
My heels and boots that I put on Facebook.
What's the idea, baby?
9.
I mean, I just walk far enough, put them on in the car and then go back to my room.
Time you do that.
Figure out how to find them.
I'm gonna chop fingers off whoever keeps touching this thermostat.
I know, but it's already high in here. Are you one of those?
Did you fix it right? It's like it's either freezing or hot. It won't. There's no in between. Well, y'all, I'm gonna try. Let's flip the room. I want my desk
I
right
like
there.
it cold.
I like it frigid.
I like it cold too.
Y'all better get used to it because hospitals are always cold to keep the germs down.
Whatever.
Especially if you're gonna work in surgery.
Oh, I'm gonna be in the OR.
Did anybody hear from Brandon on break? Where is he at? Oh. You got in the wrong Uber car. Kidnapping. You're holding hostage.
That is moving.
That's how organized I am.
Have to give you informed information.
More and more and more when you're not smoking. Because at work, I'm not eating. At work, I'm just eating. That's what it is.
My husband says that she gives me heartburn.
No, that's why I gained weight. Not smoking. Yes, I'm running. Work, all I do is smoke.
Don't even talk about weight right now.
Y'all need to not even worry about that because you're fixing to go through a whole year of stress. And that'll
Sure ain't.
make you sick.
We're done
So,
worried about it.
just eat healthy and try to do a little bit of walking at night. That's what you can do right now.
We're not even eating healthy.
Are your vessels looking like my cocoa butter?
We're trying to.
Yeah, because your bottom number is when your heart is relaxing. And so if it's high, that means your heart is not relaxing. The pressure is too high. Even when your heart is not beating, the pressure is so high. You're probably stressed, or have you eaten a lot of salty foods, or were you nervous?
Like all my family has got that part. I kind of just felt it.
Have you just smoked? If they took
I don't smoke.
Okay. Some people will smoke and then
Shit's like cigarettes.
and it'll, raise it up. But after you give it 15 or 20 minutes after their cigarette, it kind of comes back down. So you want to recheck it. It's always higher. It's always, you need to get checked. When was the last time you got the doctor about it?
Not
Never?
for that.
Birth?
Yeah, for birth.
All right. Y'all ready? Everybody back? Last leg of this chapter. All right. So, antihypertensives can be diuretics. Remember that your book goes into where they work on different parts of the kidney. Right? If they're potassium sparing, they're going to let us retain potassium. Okay? Now, some of the other antihypertensive or blood pressure meds that help fight your blood pressure are adrenergic. I can't say the word. Adrenergic. Can't say it. Inhibitor actions. Okay, they are some of our. What's our adrenergics? Remember that from reading?
Adrenergic.
Okay, so we have homework. So basically, what these drugs are going to do is they're going to go in and block that adrenergic effect. Okay, they're going to go in. One thing that helps speed this up. Your book, you can read about it in your book. Because it's too much for me to go into right now. And we'll talk about it tomorrow the next time. But there are some of these meds that are. Remember, I told you earlier with the beta blockers, you have beta 1, beta 2s that they're selective. So they can go and pick which one they want to block. And then there's some that aren't selective. They just go in and they block the whole, wherever. They don't care. Okay? So those are good, right? Because they're just like our antibiotics. Broad. Okay? They block all those sites. And what they do is they're trying to inhibit or block the angiotensin, which is something that is a vasoconstrictor. Okay? So you're going to get into the beta blockers, the alpha, and then you'll have ACE inhibitors. So we're going to get into all of these. Okay? You're going to have to read this and then come to me and we'll repeat it too, because this is not going to make sense unless you read about it. Okay? ACE inhibitors. Okay? What they do is block or inhibit that angiotensin, which is a vasoconstrictor, from binding to the sites of those cells. So, or to the nerve fibers. And there's a picture of it on page 220. See here at the top of page 220? stabilizes kind of with your whole system. This is going to block that from attaching to those nerve fibers, which tells the vessels to constrict, okay? So they go in and they block that signal, therefore keeping the vessel what? Open, dilated. Now, they are pretty good at doing that. They help, a lot of people use them. They're called, but they're angiotensin-related agents, or ACE inhibitors. They have a bad side effect. Does anybody remember what the side effect was? An irritating side effect. They have that dry, for ACE inhibitors, they have a dry, nagging cough. You'll hear them like sitting behind you going, sounds like they're trying to clear their throat constantly. And so if you hear that and you're like, you want blood pressure medicine? And they'll say yes. And you say, you don't have? No, they don't. So if they're on an ACE inhibitor, that's a side effect. It suppresses the coughing, so they're wanting to always cough. And it makes that wants to clear their throat or whatever. So they'll have that little irritating cough. And they can get that change if it gets to the point where it's bothering them bad enough, they can get a different kind of medicine, okay? So that's ACE. Also with ACEs, you don't want to take those ACE inhibitors when you're pregnant, in the second and third trimester, okay? That's just not good to take those when you're pregnant, in the second and third trimester. Okay. So beta blockers are our first one, and then angiotensins are the ACE inhibitors. And then we have our vasodilators, like we talked about earlier. They're just going to open everything up, dilate it, like your red straw, without the cholesterol in it, right? And then our calcium channel blockers. They're going to block that calcium from going in the cell, which helps that smooth muscle to dilate, and then that helps lower the blood pressure, right? And it decreases the blood pressure when I'm dilated. And I gave y'all handouts on all that, so you'll have one for calcium channel blockers, ACE inhibitors, and all that. Yeah, the pack I gave you today and the ones from yesterday. On page 224, there's some good teaching about your calcium channel blocking agents. 224 is that second paragraph, and then there's a little box about it. I think you should read over that really well if you haven't done your reading yet, or if you did your reading and you want to read it again, right? Those would be some good points, because what are we going to do when we give this patient this med? Are we just going to give it to them and walk off? No. What are we supposed to do as a nurse? Teach them about it, right? Teach them what to watch for. Teach them about this medicine. You're asking them to put a chemical in their body. Don't you want them to know what they're doing with it, right, or what to look for? So you need to understand those side effects and things to watch for, okay? So 224 is some teaching for those. All right. So like we said, the antihypertensives and diuretics can be used together or alone. Sometimes they can just start out with a mild diuretic, and that helps lower their blood pressure if it's mild. Sometimes they have to use both. But the therapeutic goal of hypertensive patient med is to get that blood pressure back down below what?
Below 140.
They want it to get back down. Because if everything's constricted, am I ever, all of my organs getting enough blood flow?
No.
So over time, isn't that going to damage it? Just like if our heart doesn't get any blood, it causes a heart attack. If our eyes aren't getting enough blood flow, it happens. You know, eye damage. Our lungs, our kidneys, everything. Okay? So having high blood pressure damages a lot of your vital organs. So that's our goal, is to help them get that back down and get under control, or else they're going to go into organ failure in various states. Okay? On page 221, there's some cultural considerations too. You're talking about an older patient with diuretics. They're going to have muscle weakness, dehydration, all that kind of stuff. So you want to definitely go over that with them. Now, what if they're confused, disoriented? Is that a good time to teach? So we're going to try to help whoever's with them, get them, or maybe give them some kind of something in writing or print if they needed all that teaching stuff that we talked about. Okay. For lifestyle changes, already talked about that. What else could I do? Diet, exercise, low-fat diet, low-salt diet, right? We know water follows salt, and if I have a lot of salt, I'm going to retain fluid, and that's going to run my blood pressure up. Low calories, low alcohol intake, all of that will help lower our blood pressure. attention is known as the silent killer. You know why? It has no symptoms. They usually don't have a lot of symptoms, or they're so vague that they overlook it. Oh, I got a dull headache. Well, how long? Oh, every day for the last 6 months. Really? But you get used to it, and so they don't pay attention to it. They will have, poor circulation, or headaches. They notice that they're blurred vision, they might be nauseated. All these little vague symptoms that they don't pay attention to, and that's what happens. They're slowly clamping down and constricting, and to the point where they don't have any circulation. Okay. So we're going to have to tell them about that. Be careful with diuretics. They can't have caffeine. Why can't I have caffeine if I'm taking a diuretic?
Because it doesn't help. I mean, it causes you to dehydrate.
If they are on a diuretic, caffeine is going to make them diurese even more. Okay? Caffeine is something that makes you diurese. And so if you have that in your system and you're already trying to get rid of fluid, do I need more caffeine? No. Because then what happens if I lose too much? Dehydrated. Okay? Electrolyte imbalances. Alright? Sometimes if they're on a diuretic, that's going to make them urinate a lot more. Okay? So what do you think happens when they realize, I'm trying to go to the bathroom a lot. I'm trying to go all the time. They become non-compliant. Because who has time to go to the bathroom 5 times in an hour? So, yeah, they do, but the rest of the world doesn't, and so they won't be compliant. They decide, I just don't want to do that. Or they can't, they're already a little bit, maybe, stress incontinent or from childbirth or whatever, urgency, and they can't get to the bathroom quick enough. And they're frustrated because they feel like they're having an accident, and then that spirals down into, I'm losing continence, and, I'm getting old, and so they will just say, I'm not taking that water pill anymore. They won't do it. And so then, what happens to the blood pressure? Starts creeping back up, okay? So we have to make sure that they understand to take that. Now, some of these, if they're incontinent, we can fix that. We can talk to them about that. There's things we can do. But some of the treatments are anticholinergics or antispasmodics. Why do you think an anticholinergic would work for somebody who's urinary incontinent?
Because your bladder spasms.
What is anticholinergic? Remember when we did the histamine stuff? The cholinergic effect? What does it do? It constricts. And also, what does it do? It makes us not have any, we don't go to the bathroom. We become urinary retention. Because it's blocking everything, it's slowing everything down, and it speeds up and it holds it off and you won't pee. Okay? And so that's why these work. Alright? Antispasmodics, if they already have some issues with their bladder, now we're giving them a water pill, we can give them an antispasmodic. Okay? There's a list of meds on page 232 that are all about that. Okay? See where it says the anticholinergics and the antispasmodics? Ditropan is a very common one that we used to give old ladies that would help with that. They're having a little elderlies that don't like to take their fluid pill. We can give them Ditropan. That'll help.
And so it helps them from not going so often.
Right.
Does that not contradict the
Yes.
eating it?
Yes. And so that's the dilemma we get in. So we have to be real careful with it. Very good. And so when they have all these treated urinary problems, we have to be real careful that they're not retaining too much fluid because that, like I said, it's going to counterbalance. And also that they're not going to get rid of any fluid. It's not good to hold that urine too long, right? Retention causes bladder infections, okay? Now, what if they had an enlarged prostate?
What do you mean?
If it's a male and they have an enlarged prostate, they're not going to be able to get rid of that fluid. And I'm giving them a fluid pill. It's going to, the prostate is enlarged, it's pressing down so they can't urinate. So we have to give them something that helps get that out. Flomax. It's one that's used real commonly for enlarged prostate.
rapid flow.
Decreases that urgency to urinate, but it helps shrink the prostate so that if they're having issues where they're still going to get rid of that fluid, but it helps decrease the size of the prostate or the pressure that it has on the bladder, pushing it out, okay? When we talk about our patients who are on Lasix, where we know that furosemide, where we know that they're getting rid of too much potassium, what are some things we can tell them to take? They can take a potassium pill, behavior, but what else can we tell them to do? What kind of diet should they eat? High potassium, so what are some high potassium foods? Cantaloupe. And so all of those are in your book, and you always want to be able to know the foods to tell your patient, because you can't just say, hey, you need to eat a high potassium diet. They don't know what that is. You have to, and they'll say, so what is the high potassium? And you need to make sure that you can tell them that, okay? So always know those. What is something we cannot take our meds with? Like these meds, our blood pressure meds. Alcohol. Well, definitely alcohol. Well, grapefruit juice. Good. Remember yesterday we were talking when we did our drug cards? You need to make sure that you tell your patient not to take it with grapefruit juice, because it's going to alter the absorption, okay? If they have problems, blood pressure problems, they're going to need frequent kidney checks, kidney function tests, and also eye exams. Remember, if I'm not getting circulation, to my vital organs, they're going to shut down. Okay? What are the signs and symptoms of dehydration? We'll just wrap it up here.
Dry skin.
Good. It's on page 235. Good, Luke. It's all over it. All over it. Good. So, we're on page 235. If your patient is on this diuretic and now if they've gotten they're dry, they're dehydrated, you need to be able to assess that too. So any patient that's on a diuretic, you want to make sure, one, that they're not having weight loss, their skin turgor looks good, that their blood pressure is not too low, because those are all signs and symptoms of dehydration. Now we've got them too much fluid out, and now they're dehydrated. So know those, okay? Let's see.
If they're on a diuretic, would they be on like a fluid restriction, or would you still want them?
It depends on the patient, how far along they are in their disease process. If they're really, really sick and they have other heart issues, then they are going to be on a fluid restriction diet. And you're pouring a lot of heavy diuretics into them, to diurese them, then they're going to be on limited. But again, that's a fine line. Once they get to a certain point, then you have to make sure that they're not too, we've not gone too far the other way. Okay. And we talked about IV fluid yesterday. Did y'all like doing the IV drip?
Yes.
You feel comfortable with the IV mask, the drip rate factor? Okay, we'll work on it. You got time. So we'll keep doing those. But again, I told y'all when I gave y'all your fluids, you had to break up into groups, that all of you had 4 different kinds of fluids. Who had normal saline? What was the stuff that you found? What kind of patient would be getting normal saline? What would I use it for?
For dehydration, possible help us push other medicines through.
Safe. It's pretty safe to push most meds through. Good. Well. Anybody else from that group remember? to know what they're for, because if the doctor orders it and they make an error, you've got to make sure that that doctor realizes that, okay? If I have high blood pressure, do I need full normal saline? If I'm a diabetic, do I need dextrose in my IV? Maybe, maybe not. So you got to know, okay? So look those up, because I'm going to ask you what the different fluids are for, okay? And they are on in your book, page 235. You need to know there's tons of them, okay? Now, who had the dextrose? What did you decide? I know there's two different concentrations.
5%. Ours was for like a diabetic. Put no sugar in it.
If it has dextrose in the IV fluids, it's going to be, it's going to have dextrose, which is sugar. So let's say my patient's NPO for surgery, or they're NPO because they've had abdominal surgery, we're trying to let their gut rest. So we can't put any food in them, but doesn't our body still need a little bit of calories?
Yes.
Yeah, so that's where the dextrose comes in. But if they're diabetic, and we don't want to just keep that dextrose running full speed for 4 or 5 days, because then we're going to see what elevate. Eventually it's going to go dark. We're not giving them the insulin to pull back up. So those IVs are really good. There's when it talks about the crystalloid mixtures, that's your sodium, potassium, chloride. Those are all your electrolytes. Okay. Calcium, phosphorus. They can add a lot of that to those fluids. Okay, depending on what the patient needs. And then for the colloids, that's your volume expanders. So let's say I just was in a really bad car accident and I lost a lot of blood. They can't get blood in me fast enough, but we can use the colloids. Some of it is plasma, but then there's other fluids they can put in too, okay, to help keep my blood pressure up. Because when we lose all our volume, what does our blood pressure do? Drop. Okay. So just kind of know those. It does matter what kind of fluid you're getting. Any questions so far? I'm going to test y'all's knowledge now on your meds. Have y'all been reviewing your meds?
No.
She's honest. No. Okay. So since this is pharmacology, you're going to have a lot of meds on your pharm test. When is our next unit test? Next week. So if you haven't been working on your farm, like memorizing, I know you've been doing your farm cards, but you need to be looking over them every day. Eventually it'll click and you'll remember those. You'll be able to see them and say, okay, that's a blood pressure med.
That's the thing.
That's how you're ready. Repetition.
But
Just
you don't ask
memorization.
no questions about me, about the name of them, or actually category.
So you're going to have to learn. Well, you're going to have both. Because if you don't know what category it is, you're not going to know what to do. Alright, so I'm going to put a list on here. And let's see what y'all can do. You can match them up.
Yeah.
Their propanol is
Wait a minute, so hydrolysine is a peripheral vasodilator, what does that mean? What does it do?
In circulation in your legs and arms.
My legs and everything.
A statin is a lipid. Lovastatin is like a lipid. A lipid ain't no
Sorry. Yeah,
Alright. Cholesterol.
their verapamil is a calcium channel blocker.
What does that do?
Blocks calcium, and gets us too excited.
So what's it gonna do to my body though?
Slow it down.
So what now? My body?
Heart rate.
And my heart.
And then their propanol is the beta blocker.
Cause how'd you know that?
LOL.
LOL.
LOL is what?
Beta blocker.
Propanol is a beta blocker. That's on your handout. And what does that do? What does a beta blocker do?
It blocks the, it
blocks beta.
it attaches to the beta receptors to slow it down.
Yes. That's slowing my heart down.
Hey, dude, it's a nitrate.
Oh, digoxin, we got, I forgot about it.
Minoxidil is a nitrate.
No, that's a.
Remember, some of them can be dual categories.
Okay, but ain't the,
So is it different?
Mine are
So
different.
it's
So it's
valid.
minoxidil and isodil. It's
Lovastatin is the hypoglycemic, right?
Yes. And she said that one. Sorry. So any of the statins are what?
statin.
They're lowering my cholesterol. And what do I need to check on my patients when they're on statins?
Their cholesterol levels,
Their
fasting.
Liver function test and cholesterol levels. Good.
Minoxidil is a nitrate, isn't it?
It can be, it's in two categories.
It's a nitrate and a calcium blocker. Or no, it's creatonic. Oh God, give me a minute.
Is it
vasodilator.
Which one?
is the Johnson the cardiotonic
Minoxidil.
or nitrate?
It's
Cardiotonic.
It's a nitrate and a vasodilator.
digoxin is
It's a cardiotonic.
because what's it do?
It stops the heart.
Slows it down, relaxes it. Think of if I had too many tonics, I might slow down, right? Kind of numb up, feel numb. Digoxin. What's the deals?
The dills are nitrates.
What else do they do though?
They're beta blockers. Or something close to that. Anti-anginal.
Are you guessing?
Yes, no.
She is. She's just throwing.
I didn't guess the nitrate. I just
The
figured out the
minoxidil
second one.
can be it's a peripheral dilator. They could be one of those that can kind of go with both. Peripheral vasodilator.
And what is?
Minoxidil.
It's a nitrate too. Oh. See, I just couldn't figure out the other one.
I thought you said
What's
India
isor-
is the isodil.
Isodil is a nitrate. Good. What does a nitrate do? Chest pain, anginal, anti-anginal.
None of them are just running.
Yes.
What is
Because
it?
remember, dig is slowing my heart down. If I'm at AFib or flutter, I'm going to be on dig. So that's an
That's not the
antidepressant.
only one, right? I was gonna say verapamil.
Y'all thought I was going to make it easy?
Yes.
So that's just kind of what you need to do, like when you're studying, know that, because that's the kind of questions I'll say. This patient's on this. What kind of medicine is this? And you gotta know. You gotta know what they are, because if you don't know what they are, you're not gonna know what to do or what to watch for your patient. Okay? So those are all on in your book on that those 2 pages that we talked about earlier.
Okay.
I lost my place in my book.
Somewhere on
It was 2 pages and it had for the whole chapter. It broke it down by each.
No.
By each category. Okay?
232.
What page?
232?
No, it's urinary.
Yeah, it's page 225. nursing measures from lecture, and y'all are picking up on it and you're remembering it, but it won't do you any good if you don't know that drug's name and what it is. Y'all already know what those are and what they do, but you're not being able to match them up yet. So keep doing your flashcards, keep doing your drug cards so that those can connect. If you can't connect them, this is useless information.